You're listening to The Dead Prussian, a podcast about war and warfare.
There's a lot of focus these days on the mental and physical trauma soldiers go through when they go to war. There have been a lot of hard-learned lessons recently on the effect of this type of trauma. Previously on this show, we have studied how nervous disorders were identified and treated in the First and Second World Wars. We're going to continue that journey today, and we're going to talk about the Korean War. G'day listeners, it is your humble host here, Mick, and welcome back to the Dead Prussian podcast. My guest today is my most prolific guest and a favourite of you listeners. It is, of course, Dr Meghan Fitzpatrick. Now, for those who have forgotten, Meghan is a researcher with extensive experience in war studies and history. Her interests include the health and welfare of serving military personnel and veterans, psychological adaptability, and resilience. She is a postdoc and assistant professor of military history at the Royal Military College of Canada in Kingston, Ontario. She recently received a prestigious fellowship for her work from the Social Sciences and Humanities Research Council of Canada. Her book, Invisible Scars, Mental Trauma and the Korean War, comes out this August with the University of British Columbia Press. Hi Meghan, welcome back to the show.
Hi there. Thanks for the invitation.
No, thanks for accepting it yet again. It's great to see guests returning, and it's good to see someone beat Hugh Davies in terms of numbers of times appearing on the show.
Well, I aim to please.
Now, can you provide a quick overview of the understanding of nervous-related war disorders in the period before the Korean War?
Sure, I'll try to provide as brief as possible.
Yeah, that's
overview.
Right. Our listeners can go back and listen to the other two episodes if they are a little nervous.
Absolutely. Well, both clinical and popular understandings of these disorders really shifts and evolves throughout the first half of the 20th century. So we discussed previously during our previous conversations that modern military psychiatry really starts to emerge during the First World War. And this is very much in response to the overwhelming number of psychological casualties that are suffered on both sides of the battlefield. And these are casualties that present with a really wide variety of symptoms. So that could include anything from anxiety, depression, heart palpitations, to more extreme things. So things like functional deafness, blindness, even the paralysis of limbs. And originally, the medical community, they believed that these disorders are the result of shell concussions, so hence the term shell shock. But they soon discovered that this isn't actually the case. And in fact, the majority of the patients they're dealing with are nowhere near a shell concussion when their symptoms first originate. So the symptoms, in fact, are tied to prolonged emotional, psychological stress, the stress of living in a war zone, dealing with the possibility of death, injury for months at a time. So during World War I think that doctors, they take such a long time to make that link, to make that connection, because we're dealing with previously very healthy, robust young men, and there's also a huge stigma that's surrounding mental illness at this point. So psychological problems, they're largely seen as being connected to hereditary family issues. Frequently, they're associated with women, with being effeminate. So I think that for doctors, many of them would have been hesitant to attach that label to a young soldier. Now, eventually, they do make the leap. And during the war, they reach the conclusion that everybody has a certain breaking point. Now, some of your listeners are probably pretty familiar with Winston Churchill's personal physician, this guy called Lord Moran, and he famously described courage as a bank. So, you continue to make withdrawals over time, and all of us have different balances, but we eventually run out of money. So at the time, psychiatry and psychology, as disciplines go, they're still in their infancy, and they're still developing as professions. And as well as that, you've got the clinical understanding of psychological trauma. It's still quite hazy. So there's an incredible number of different treatments for conditions like shell shock. And that could be anything from talk therapy on one side of the spectrum to something as extreme as electric shock on the other. But that's usually back at base hospitals. So in contrast, treatment on the front lines is firmly pragmatic. Manpower is the primary consideration at all times. And that's something that remains true of modern military psychiatry probably today. And it's a strange sort of tension. So the goal isn't necessarily to restore the patient's previous state of mental health. What it is to eliminate those symptoms and allow the person to function safely and effectively as a soldier. And that's the focus, is returning the man to the unit. And it ultimately leads to the development of forward psychiatry, which we've discussed before.
Yep.
So the tenets of forward psychiatry that I've described, they're all summed up by kind of a very clever acronym, PI. So proximity, immediacy, and expectancy. In other words, treat the patient as close to the front lines as you can. Treat the patient as quickly as possible. And then treat them with the expectation that they're going to recover, successfully return to duty. Now, given all of those developments, you would think that military psychiatry would continue to advance during the interwar period. Unfortunately, things are never that simple. So when the war ends, the majority of doctors and psychiatrists in uniform, they go back to civilian practice. The war itself had presented them with a lot of opportunities for clinical experimentation, for some professional advancement. But peacetime doesn't offer the same kind of opportunities. And what that means is a huge loss of expertise as well as institutional knowledge for the military. And that only becomes noticeable, though, when the armed forces start to gear up for war again in 1939. Now, in addition to that, you've got the British government holding something called the Commission of Inquiry into Shell Shock. And its report comes out in 1922. And they go through a lot of witnesses, take a lot of months to finish this, but their conclusions are pretty ambiguous. And old ideas start to reassert themselves. So ideas like if somebody broke down during service, it has to be linked to some sort of pre-war history of mental health problems, so family history. And it puts the blame squarely on the individual rather than the traumatic event. And given the huge costs of pensions at this point, Canada, the UK, Australia, all the major Commonwealth players, as well as the United States, all of them invest very, very heavily in the development of psychological selection and screening programs when it comes to World War II. Because what they believe is that by having modern science on your side, you're able to somehow identify men who are going to be vulnerable to breakdown and then screen them out before they're able to pose a risk. But it takes them a few years to realize that screening isn't always the most effective thing, and to start investing more heavily in clinical treatment in the field. So the principles of forward psychiatry, they're only really rediscovered, and they start employing them again at divisional level during the Western Desert Campaign in 1941. And as the war expands, so too do the roles that are available for psychiatrists as well as psychologists. So it's delivering clinical care, selecting officers, figuring out how to boost morale. You've also got a lot of experimentation in things like group and occupational therapy, as well as the use of drugs, so sedatives, amphetamines. And that idea that everybody's got a breaking point, again, that reasserts itself. So you've got studies measuring decline in combat effectiveness over time, the correlation between direct combat exposure and anxiety. And very interestingly, the terminology also starts to shift. So you've got doctors moving from using labels like shell shock to using a word like battle exhaustion. Because the word exhaustion, what it implies no blame. So suggests that you're temporarily exhausted, but that you're able to recover from that. So the frontline treatment for these kinds of things, also, it really stays on the pragmatic side of things. So once again, the focus is on returning the soldier to the field. So that's really where we are when it comes to popular or clinical understanding of war trauma when Korea first erupts in the summer of 1950.
Cool. So, one, I do like forward psychiatry because I like pie, and that's just a fact. But our listeners may also know Winston Churchill's physician, or might know Winston Churchill's physician, because he was very handy at prescribing prescriptions that contained a requirement of whiskey, gin and champagne whenever Churchill was travelling the US.
Very true.
Which means he must be a very reliable doctor, but it's an excellent metaphor he used with the bank. It's a great way of thinking about courage. Now, moving on to the Korean War, what kind of casualties did the doctors encounter there? Was there a high rate of psychological trauma?
Well, first off, I think I need to explain what kind of war Korea was for any of this to make any sense. So from the summer of 1950 through to 51, Korea is a highly mobile war. When the American troops arrive first off in the summer of 1950, they are almost immediately pushed back by the invading North Koreans. And that's all the way down to the Busan perimeter on the south coast. Now, eventually what happens is that UN forces, of which the Americans are a large part, they manage to pull off a amphibious landing at Incheon. Many people will know about it, Operation Chromite. And what that manages to do is it cuts off the North Korean advance. And then they start moving forward towards the Yalu River, which is on the border between China and Korea. And they manage to reach there by about October 1950. So the problem now is that the Americans, the Chinese are afraid that the Americans are planning on pushing the war into Manchuria, so across the border. So what they decide to do is to join the North Koreans, and this is a decisive turning point in the war. So it continues it prolongs it for years. And throughout that winter, the UN coalition, which includes many Commonwealth countries, and they eventually go on to form a division, well, this coalition has to endure several major Chinese offensives. And that includes one in the spring. And this is where you get the most famous battles of the Korean War, so at least when it comes to the Commonwealth. And that includes the Battle of the Imjin River, as well as Kapyong. Now, eventually, though, the front line settles along the 38th parallel, a little bit arbitrary, and negotiations for a ceasefire start, and they'll continue for the next 2 years. And during that time, very long period of time, the war becomes essentially static. So you've got patrols, skirmishes, capturing prisoners. This is definitely a ground war. Mm-hmm. So the Chinese, generally, they attack at night to be able to negate the UN's dominance in the air. And battles are generally small scale. So the goal changes from mobile to the static phases. So it goes from defeating the enemy altogether to just helping to improve your side's particular negotiating position. So when it comes to psychological casualties, they change over time in alignment with this. So as you can imagine, they're exceptionally high in the beginning, mobile phase. So July 1950, U.S. Army is categorizing about 50 men per 1,000 as neuropsychiatric cases, and that figure goes up. So it skyrockets up to 158 men per 1,000 the following month. And at the time, observers very derisively referred to this period as the Great Bug Out. Most of the casualties, really, that we're dealing with at this point, we're talking about anxiety conditions that are brought on by direct exposure to combat. Yep. So clearly the number and the type of casualty changes when the war becomes static, though. So American admission rates for mental health problems, they're about 32 to 36 men per 1,000 from July to October of 51, and that's comparable to many theaters of World War II. And as the front line stabilizes, there's fewer casualties, so the admissions decline correspondingly. And the same can be said for the Commonwealth Division. So throughout 52 to 53, psychiatric admissions to medical units, typically about 5 to 9% of the total population, patient population, I should say. And we're dealing with fewer cases of battle exhaustion. So instead, what we're handling is other diagnostic categories. And when it comes to the Commonwealth, the most common diagnosis, I should say, is psychoneurosis, and that's followed by character disorder. Now, psychoneurosis is a pretty generic term for anxiety, but it's about 50% of all Commonwealth patients. Okay. And only psychiatrists, they've been using the term psychoneurosis since about the early 20th century. And this was something that I found very difficult when I was researching this because it's incredibly generic. And in all the teaching manuals that you read at the time, it's very broadly defined. So it's an illness, what they say is resulting from the exclusion from consciousness of powerful emotional charges.
It's very clear.
Yeah. And then in contrast to psychoneurosis, you've got character disorder. And that's not distinguished by mental or emotional symptoms, but by behavioral problems. So it's largely applied to people who are considered to be troublemakers. And the number of cases goes up during quiet periods, so when troops are put into reserve. So this category is people who are suffering from alcoholism, drug addiction. And I should point out that drug addiction wasn't actually seen as a major problem for Commonwealth authorities. Okay. And it doesn't appear to be one from all the evidence that I've seen. But some of the American sources do suggest that opiate addiction was quite prevalent amongst American servicemen. Okay. And they point to Busan, where there was a thriving black market drug trade as the source of all these problems. And it would be fascinating to be able to do a little bit more digging, but when it comes to the Commonwealth, I haven't seen the same kind of problem in place. Mm-hmm. So apart from those diagnostic categories, you've also got post-combat syndromes. And those are typified by unexplained medical symptoms. Yeah. So for most part, the chief causes of admission to base hospital are respiratory, they're gastrointestinal, and their skin reactions, all the common things you would expect to see. Mm-hmm. And Commonwealth medical personnel, they recognize that most of these cases display clear physical signs of disease. But they also know that there's psychological factors that are part of this. So in response to that, the Assistant Director of Medical Services for the division, he told all of his medical officers to refrain from evacuating patients with unexplained medical symptoms too quickly. And the reason he said this was he says that the conditions were often bodily responses to anxiety, resentment, and low morale. And he argues that these somatic physical conditions are a way to relieve your anxiety. So it's an interesting theory. Yeah. And it does guide medical policy. And the British and the Canadian records that are available don't really make it clear what kind of numbers we're dealing with. But having said that, the Americans published a study in 1951 that's U.S. Army orthopedic patients. And the authors concluded that psychiatric symptoms were present in about 56% of patients, so a little bit over half. So it's plausible that the Commonwealth figures are comparable to the American, especially when you consider that Commonwealth and American troops are living in a similar environment. Yeah. And then throughout the winter of 50-51, cold injuries are also a very, very big problem. So you got about 8,000 servicemen treated for frostbite, trench foot, all of those nasty things. Yeah. And the conditions in Korea are very extreme. I don't think many people know that they were enduring minus 30 degrees Celsius winters. Yeah. That's the kind of life they're in.
Yeah, sounds wonderful.
Yeah, exactly. And it sounds like a Canadian winter.
Yeah.
Commonwealth doctors investigate this issue and look into it. They become pretty convinced that cold injuries can't be explained by temperature or wind chill alone. And the Americans reach the same conclusion. And what they do is they send research teams to look at it. And they eventually conclude that stress and morale, as well as individual mental health, played a role in how many cold injuries they were seeing. Yep. And that leads the entire UN coalition to start enforcing a very strict inspection regime, to brief servicemen about the dangers of cold weather. You know, you've got officers being forced to check their men's feet and the socks every single day of the winter. And they also take a really punitive stance on cold injuries. And they treat them as a self-inflicted wound, so as an SIW. And during the 20th century, as I'm sure is apparent for many people, they know this, that the military generally severely punishes people who present with self-inflicted wounds, with SIWs. And Korea is no exception. So Commonwealth Division takes a really hard stand on this. They don't see servicemen who are treated for SIWs as psychiatric casualties. They're offenders, and they're deserving of punishment in their minds. So you can imagine they're pretty alarmed to discover an increasing number of accidentally wounded soldiers in 1951.
Yeah.
And the Americans are also seeing a similar number of soldiers coming in for accidental burns, gunshot wounds, all sorts of things.
Yeah.
And then things eventually come to a head when the British Director General of Army Medicine, he shows up for a tour of the Korean theater in February of 52. And he's panicked when he discovers that 24 out of 83 patients in the base hospital that he sees that day, all of them are being treated for accidental gunshot wounds. And he is absolutely convinced that these guys have injured themselves. So he immediately contacts his superiors back in the UK. And for him, that means the chief of the Imperial General Staff, so Field Marshal Slim.
Yep.
And Slim, very shortly after this, he gets in touch with the divisional commander, a guy named Major General Castles. And Castles is very quick to reassure him. And he tells him that, a portion of these cases are actually accidental wound cases. And he knows that some are self-inflicted, but most of them are genuine.
Mm-hmm.
He also says, my officers would never hide evidence of self-inflicted injuries. And he goes so far as to say he would be keen to court-martial the man and ensure that he was punished as far as possible. So anyone presenting with an SIW. Now, despite what Castles just said, Slim takes the case further, and he gets the commander-in-chief of Far Eastern Land Forces to investigate, which actually ends up being a bit of a waste of time.
Yeah.
Because most of the accidents were genuine, according to this man who issues a report as well. And he says that they're the result of intense cold, which can make fingers slip, the unreliability of Sten guns, jumpiness and night fighting, lots of other reasons for this. And he also reports that divisional morale is quite high. It's excellent. And reports of SIWs do start to go down over time. And the division monitors the situation carefully. Now, having said that, Castles, he's quite keen to be able to prosecute people, although he doesn't get much of an opportunity to do so. And in his letter to Slim, how he sees these people is quite telling when he says that these men are weaklings who had taken the easy way out. So he has a very clear stance on it. So you can see from all this kind of scope of psychiatric injuries, we're talking about many different types of psychiatric casualties changing over time. So acute anxiety states during the more mobile phase of the war. And similarly, these kinds of cases appear when troops are engaged in combat directly. Mm-hmm. However, then you get a rise in character, behavioral problems in quiet periods. And medical officers also have to deal with psychosomatic conditions. And the problem with those is they're not so easy to recognize or to diagnose.
Well, it sounds like the field doctors had quite a bundle on their hands.
Yes.
The changing character of the war at the time tended not just to affect those making the tactical decisions or operational decisions, but also those who were looking at a skin rash trying to figure out whether it was just the phase of the war or the living conditions.
Impact everybody.
Now, on to these poor doctors, and I'll call them poor doctors because they deserve my sympathy. How did they treat the disorders in the field? Was it different than in the past?
Yeah. During the Korean War, medical officers and psychiatrists, they apply essentially the same basic principles to treatment as their predecessors do. So once again, you've got that main goal to preserve manpower. There's an article by a man called Dr. Norman Camp, and he discusses in it the ethical challenges for psychiatrists in reference to the Vietnam War. But what he says is actually equally applicable to Korea. And what he says is actually worth quoting to a certain degree. He said, the combat psychiatrist's foremost responsibility is that of stemming the flow of individuals who manifest a psychological incapacity or reluctance to soldier. He may be obligated to deny a psychologically traumatized soldier's expectation of medical exemption from further exposure to combat, to conform to the military's expectation that the soldier should be returned to the environment. And I think if you think about that, step back and think about it, it really sums up the thrust of psychiatry both in Korea and World War II.
Yeah.
The main goal always is returning as many soldiers to duty as you possibly can.
Yeah.
So in light of that consideration, the same principles, that PI principles, are applied in the field.
Mm-hmm.
And in Korea, that's to great effect. So Commonwealth doctors were regularly returning well over 50% of troops to some form of duty.
Okay.
And of course, you've got to be careful with numbers because psychiatrists are known to have inflated their rates of success to a certain degree. But I have been able to find evidence to corroborate those figures.
Okay.
And the Commonwealth did have a policy of re-employing men along the division's line of communications if they couldn't go back to that original unit.
Yeah, okay.
But when it comes to the Commonwealth and the Americans, if you're trying to compare them, there is a difference in treatment, and that's mainly because of resources and manpower. So the U.S. Army Medical Corps is extensive. It's huge in Korea.
Mm-hmm.
They have extensive resources, and psychiatrists are deployed at divisional level within a few weeks of deploying.
Yep.
And they also have these traveling psychiatric detachments, very interesting thing called KO teams. And they're there to be able to boost the existing services. So they're in the areas that have the greatest number of casualties.
Yep.
They're fully mobile. They have all the latest diagnostic technology. They've got a psychiatrist, a psychologist,
Yep.
social workers on staff. And then what they do is they roll into a medical clearing company, they set up a full-blown neuropsychiatric center, and they have these specialized units back in Japan for further care.
Yep.
Now, in direct contrast to this, the Commonwealth is pretty limited.
Yep.
So before the division is set up in July of 51, there's a very small psychiatric ward at Commonwealth headquarters, which is back in Japan. But there's relatively nothing else other than that. And the majority of the patients who are sent to Japan, they're sent there automatically because it's impossible to keep them in theater at that point. There's not enough in terms of resources.
Yeah.
Now, thankfully, that does change over time. So once the division is formed in the summer of 51, a divisional psychiatrist is appointed. They're always a Canadian or a British officer, actually more often Canadian.
Yep.
And they run a really small 44-bed ward hospital. A ward, I should say, at the 25 Canadian Field Dressing Station. And that's the division's central hospital.
Okay.
And psychiatrists, what they would do is they tour the frontline field ambulances to assess patients. And then they take the most serious cases with them back to the field dressing station. And typically they're sedated on admission. And they usually would use a barbiturate like sodium amytal, which was typical at the time.
Mm-hmm.
And during World War II, doctors were using drugs like sodium amytal to help soldiers sedate them, as well as to help calm psychotic patients.
Yeah.
So used it during, for instance, the evacuation of Dunkirk in 1940 is when they used this.
Yeah.
The theory is that by sedating the patient early on, you're somehow able to stop the neurotic patterns of thought in their tracks.
Yeah.
And keep them from remaining in somebody's brain. So that's the theory behind this.
Yeah.
It's debatable as to whether or not it's a great theory, but it is the theory at the time. And Commonwealth doctors adhere to exactly that theory in Korea. So then following the sedation, patient goes through the typical physical and psychiatric exam. Sometimes they would be sent for more tests at an American holding company. The division had very close, friendly relationship with the Americans, and was welcome to make use of their resources when they needed them.
Yep.
And then once a diagnosis was confirmed, patient was generally required to attend about 1 or 2 sessions of brief psychotherapy. But this is not like the Freudian psychoanalytic kind of therapy.
There's no field couches being set up.
Yeah, there's no couches in the middle of a field here. So these stations, they're not intended for that. They're presenting the psychiatrist with a chance to evaluate the patient, to decide if they can return to duty. And they're primarily designed to reassure the man that he's going to recover.
Yeah.
So they're not there to uncover deeper emotional distress. In fact, they probably generally avoided coming to trying to find any deeper seated issues.
Yeah.
I think they probably would have avoided that.
Yeah.
So if the patient needed further hospitalization, which wasn't very common, they would be sent to the British Commonwealth Hospital, and that's back in Japan.
Yep.
And they have a psychiatric ward, but once again, turnover time's pretty quick.
Mm-hmm.
So most patients, whether they were physically or psychologically wounded, they only spend about 10 or 11 days in hospital before they move on to either a convalescence unit, where the aim is to transform the patient into a soldier again. So they use physical exercise. So they're very much this whole power of exercise calisthenics regime.
Yeah.
Or they're just sent back home to their home country for more extended care. It would very much depend on the individual.
Okay. It's interesting to see the physical training aspects kick into it now that we're seeing a lot of modern programs doing the empowerment for troubled veterans through sport and physical activities. So it's definitely got some modern echoes that a few people can link. It's also interesting seeing the 1 to 2 sessions, almost like a pat on the back. You're doing good, buddy. You're okay, and we'll just move you along. But you can understand the sort of pressure that these medical personnel were under, particularly in a war that was a very mobile war that rapidly became a static war. Now, did the Commonwealth countries take any steps to protect the mental health of soldiers in general? So I've talked about treatment of those afflicted, but what about the protection of the soldiers broadly?
Right. Well, yeah, they did. Morale plays a pretty crucial role in protecting military personnel from the onset of psychological problems. And of course, the concept of morale is difficult to understand and to define accurately. In fact, it was, I think, the most difficult thing when I was writing my book and trying to understand what morale consists of. And it can be just as hard to try and measure it because it's not really directly quantifiable. Now, having said that, it is a powerful variable, and I do think it does have an impact on operational effectiveness. And by all accounts, junior, senior officers, outside commentators, the Commonwealth Division did have very high morale for the most part. And I would argue that there's probably several factors that contribute to that. So first off, you've got strong leadership. But once again, you can go to town debating what constitutes an effective leader.
Yeah.
Endless books about this subject.
Yeah, that's a can of worms.
Yeah. But in this case, senior Commonwealth officers, what they really do is they act as protectors of the soldiers that are under their command. Mm-hmm. So the Americans, they take a very manpower-intensive approach to operations in Korea.
Yep.
Now, in contrast to that, the Commonwealth Division, it can't afford to do that.
No.
First off, you don't have the men to do it. And it takes months for reinforcements to arrive on a troop ship, so you're not going to waste your resources. And with the recent experience of World War II, I think that Commonwealth officers treat manpower as a pretty precious commodity at this point.
Yeah.
They're determined that if they see casualties, it's only going to be for a significant result.
Yep.
And they negotiated and they debate with their American superiors, much to the Americans' chagrin, when it comes to operations, and they are not afraid to say if they think a military operation is unsound. And the second element that I think is key in fostering good morale for the Commonwealth is limited tours of duty. So Division has a one-winter policy. Like I've been discussing, Korea had notoriously cold winters. Yeah. And this is a limited war, so we're talking about a war that's fought for very shifting political goals. And it's not always easy for guys on the ground to understand what they're fighting for. I mean, when American General James Van Fleet, he gets to theater to take on his command. And he has a press conference, and reporters ask him, General, what are we here in Korea for? And his response is, I don't know. So if a man like that at the top of the chain doesn't know the reason, you can imagine that for many of the guys on the ground, they have no idea.
It would have been great for the soldiers to hear that.
Yeah, exactly. So a set tour provides you with a tangible goal, an end date. And then as well, the division rotates men in battalion-sized groups. So that means you're training, you're living, you're fighting with many of the same guys for well over a year. And that helps to foster that small group cohesion, esprit de corps, in direct contrast to the individual points-based rotation system that is maintained by the US, which also becomes problematic both in Korea and Vietnam in kind of interrupting group dynamics.
Yeah. Okay. That general's comments have just got me stumped. Maybe he should go back and understand that the political objective might have helped him not just in dealing with how to protect his soldiers from mental illness, but also and injury, but also just how to do his job in general and achieve the political objective that his country sent him there for.
Absolutely.
Now, what happened to the psychologically traumatised, injured veterans when they returned home? Were lessons learnt during this period, and were they applied later?
Right. Well, unfortunately, this is where things start to fall down.
Okay.
So, arguably, the Commonwealth Division, they do a pretty good job at returning traumatized servicemen to duty in theatre over the short term. But they fail to support these men in a very meaningful way when it comes to the long term.
Yep.
So when these guys come home, they are entitled to essentially exactly the same benefits, pensions, medical care as their World War II predecessors.
Yeah.
But it's accessing the system that is the problem. The system itself, and this would have been a problem for World War II veterans as well, is not designed for the psychologically wounded. So the impact of poor mental health is not directly or easily quantifiable in a way that's easy for a pension system to figure out. And disability claims, they're assessed by these war pensions committees. And they vary in size from country to country, but they usually include prominent members from the community. In Australia, they were required to be veterans themselves. But New Zealand is the only major Commonwealth country where they require a doctor to serve on the panel. So in other countries, what that means is that panel members, they can access medical opinion, but they themselves are drawn from a wide range of professions.
Yeah.
So what that means is that they lack that basic medical education. You're asking a group of people with almost no medical education to fairly judge very, very complicated cases of psychological injury. Fairly. Yeah. So then you've also got the problem of the pensions legislation itself, because it's very imprecise in terms of the language that is used. So throughout the Commonwealth, the main criteria for entitlement to a war disability pension is an incapacity arising out of or aggravated by active service in war. Now, when you think about that, those terms are actually pretty vague when you start to dissect it.
It's a bureaucrat's friend.
Yes. And it could be really tough to determine the origins of a psychiatric disorder, especially, again, for a group of people with almost no medical education. So because the system is so complicated, it's so full of potential pitfalls, it's also very potentially antagonistic. And because of that, many veterans just choose to keep their pain private, deal with it as best they can, friends and family. And I think what's most illustrative of that is the UK and Canada, they're responsible for over 80% of Commonwealth Division strength. So as a result, they have the largest number of Korean War vets.
Yeah.
But in 1956, only 3% of British or Canadian veterans who served in Korea were collecting a pension of any kind.
Oh, wow.
So only 3% of them. And that's a very small figure. And then in the past, you've got, veterans organizations like the Legion, the Returned and Services League. They offer alternative forms of support. So they provide a venue to relive memories, vent present frustrations. And many Korean vets did find an outlet in those groups.
Yeah.
Now, having said that, some local branches are not as welcoming. So many of the veterans that I had the opportunity to speak to, they described being turned away from their local branch. And they were given the reason that they simply weren't veterans. And the opposition that they encountered was largely because of public perception.
Yeah.
So during the 50s, the Korean War is characterized as a police action, not a war. So again and again, politicians describe it as a police action.
Really?
And then exactly. And troops deployed they're primarily volunteers. They're serving limited tours of duty.
Yeah.
And the scale of public involvement in this war is limited in comparison to prior conflicts.
Yeah.
And veterans groups who we're talking about, they're chiefly composed of men who fought in World War I, World War II. So for them, what's going on in Korea contrasts quite sharply with their own experiences of war and how they understand the term veteran. But it's unfortunate because what it does is it denies many of these Korean War veterans a venue where they can grieve.
Yeah.
So there's absolutely no public space for their memories, their sense of loss, and it still rankles with the remaining veterans.
Yeah.
And it also begs the question, why do we commemorate one war over the other? So when you really start thinking about it, and in studying Korea, I've discovered that it's really the experience of coming home and how society receives returning veterans. That's just as crucial to their recovery as any clinical treatment will be. And that's one of the kind of big, important lessons that I think we probably have to take away from all of this, is that even if you manage to successfully treat people in the short term, so in theater, you really have to keep an eye on the long term.
Yeah.
You know, you have the example of Vietnam. Initially, I don't think a lot of people know that Vietnam was seen as a success story in terms of mental health care.
Really?
Yeah, exactly. U.S. Army psychiatric casualties in Vietnam were 10 times lower than in World War II and 3 times lower than in Korea. And that's smaller than any recorded in previous conflicts. And these results are commonly connected to forward psychiatry, to less intense fighting, to shorter tours of duty, lots of those things. But what happens is, again, everything falls down in the long term. So there's a lack of those support systems in place when veterans return home. Now, in contrast to Korea, Vietnam is also a highly controversial war, and that reception certainly impacts on returning veterans.
Yeah.
Now, you can't always predict or control how the public's going to react to returning veterans. You can't control that. But what there is a need for is sufficient support systems and safety nets to help veterans transition to life after war. So forums where they can express themselves and process those experiences. But what I said with Korea, it really just brings up big questions. So why do we choose to celebrate? Why do we choose to commemorate or remember one war or one group of veterans over the other? And I think these are questions that we rarely actively engage with, but we need to, especially if we plan on continuing to send servicemen and women into danger on our behalf.
Yeah, I think the idea of Korea being the forgotten war is one that's foreshadowed a lot of military operations, especially the UN actions of the 1990s versus the modern war on terror. You have very, very different situations military personnel were going in, but quite often they were still seeing the worst acts that you can see and that humanity can be involved in, and yet there always seems to be a divide between whether or not someone else's tour was as good as someone else's, and maybe there should just be a realisation that lots of them saw awful things. And the idea that, you know, when the established bureaucratic systems fail, you've usually got these support networks in these advocacy groups. But even with the advocacy groups not supporting the veterans, it sort of rankles, I guess, with the way that we see the role of these groups, who are these days particularly vocal in the way that all veterans should be treated. One final question before we get on to the actual main question of the show. So this will be the penultimate question. There's a big word for my New Zealand listeners. How is this particular topic, other than as a topic, you know, for historical study and a really good reason to buy your book in August, but how is this relevant to modern military and medical institutions?
Right. Well, I think as both of us know, war is a pretty chaotic thing.
Yeah.
And at times the same is true of military operations. And I think that for those who are in the middle of it, it can sometimes be difficult to see the forest for the trees. So examining historical case studies like this, what it allows you to do is to step back outside of that chaos and to objectively look at what your predecessors did. So what they did well, what mistakes they made, and maybe derive some basic lessons out of it. Now, of course, you can't apply exactly the same solutions to a different campaign, but the basic lessons are useful. So, for example, those essential principles of military psychiatry, they're the same. So the preservation of manpower, treatment shaped by proximity, immediacy, expectancy, that remains the same. And I'd also argue that the Korean War has a lot in common with modern military operations. In fact, far more than a campaign like World War II. So in Korea, we're talking about working out of static positions. Soldiers have to patrol and infiltrate enemy territory on a daily basis.
Yeah.
They're working within a multinational coalition.
Yeah.
This is a limited war. It's fought for shifting political objectives.
Yeah.
In fact, political necessity dictates the direction of events on the ground.
Yeah.
And destroying the enemy is not necessarily your end goal. So, and in addition to that, you've got declining public support. And I think these are things that would sound very familiar to modern military personnel.
Yeah.
And there's a great deal that we can still learn from Korea because of that, both in terms of the medical side of things as well as beyond that.
Yeah, it's when you describe it like that, it strikes a chord of familiarity without having studied the Korean War in depth at all. Megan, it's been great to talk about pi again, and also about this very, very important topic that continues to be an issue and will be as long as the human psyche is involved in war. The human psyche always will be, because as Klaus had said, it's an act of human intercourse. However, you can't use that in the next question. My next question is one that all the guests get, and this is your third time answering this one. It'll be interesting to see what your response is third time round. But every guest has to answer and finish the sentence. War is. So I ask you to finish the sentence. War is.
Right. Well, I really struggled to come up with a new way to answer this.
Well, it has to be new.
Right. But in thinking about it, and it is kind of connected to your answer, at its heart, I think that war is a uniquely human experience. So while the way we fight, it's changed, and technology has certainly advanced, war is still shaped by individual men and women. And for me, that's what makes it interesting. That's why I got interested in the first place and why it continues to be worth studying.
Excellent. That's a really good definition, because you've had 3 cracks at it, and it'll be very, very difficult the next time we get you on the show.
Exactly.
Thank you very much for coming on the show. Good luck with marking all the essays and research papers from your students. I'm sure it's a lot of fun. Being a student at the moment, I know that writing them is a lot of fun. But thank you very much for coming on the show.
Absolutely. Thanks for the invite.
All right, listeners, well, thanks very much for listening, and thanks for all your support. As you know, recently we've launched a merchandise line. We've also got support sections on the website, and we have we don't have any iTunes reviews because no one's been throwing any stars our way. So jump online and throw us some iTunes reviews. There's also big news coming out from TDP. I'll give you more info later on down the track, but there is a second production in the works, and I will not be the sole host of this next production, so you'll have both this show and another one to fill your podcast playlist. But until next time, listeners, grab a book and crack on.
Join the conversation with us on Twitter at Dead Prussian Pod, on Facebook at the Dead Prussian page, or on our website www.thedeadprussian.com. All show notes for this episode, as well as copyright information, can be found on the website. The Dead Prussian podcast is written, produced and hosted by Mick Cook. It is co-produced by Amanda Levito. The music used throughout is Caught in the Beat by Broke for Free and is used under a Creative Commons Attribution license. All opinions expressed by individuals on the podcast are those of the individual and not necessarily representative of any other organisation.